Let me start by thanking the organizers, the Bloodless Medicine and Bloodless Medicine and Surgery Society, for inviting me to discuss on management of obstetric hemorrhage without blood transfusion, which I think is also regarded as bloodless management of obstetric hemorrhage. It is nice to be here to discuss something that is very dear to me. Let me say that I don't have anything to disclose because there's no interest. I'm working in University of Calabar Teaching Hospital as shown on the screen there. This is where all the activities that I have done so far that has been undertaken. It is a tertiary institution with multidisciplinary units, which is essential for management of obstetric hemorrhage in a bloodless manner. Then I'm going to discuss this on the following outline: introduction, our own experience, the concepts of obstetric hemorrhage, and others. By way of introduction, obstetric hemorrhage is a leading cause of maternal death and morbidity worldwide. And you recall that obstetric is a bloody condition. When hemorrhage is added to it, it becomes devastating. So it is a miracle and somehow something that we need to do so that mortality will not be accentuated in a woman that has obstetric hemorrhage. The incidence is more in the developing countries of the world and account for about 30%, a third of direct cause of maternal mortality. Like I said, the prevalence in the developing world is almost half of what is obtained in most developed countries. And it is highly preventable. The maternal death from obstetric hemorrhage is highly preventable using the available technology in a timely manner and an effective way. So it is something that we know that us as practitioners, we have to be involved to avert this calamity, because both the incidence, mortality associated with this condition can be prevented. It's also associated with severe maternal morbidity. It is noted that a woman that bleeds, apart from the immediate problem that it has, there's also a remote and long-term complication that these women have, such as renal problem, residual anemia, which sometimes, mostly in our developing countries, may be devastating, may be even difficult to control. And so it's better to institute basic and effective management in these women to avert this severe maternal morbidity. The figure on the screen there shows the morbidity associated with severe obstetric hemorrhage. If hemorrhage is so high in such a way that blood is transfused, the level of morbidity is higher. And between 1993 to 2014, it tends to go higher in this study that was conducted in the United States. And you can see the green color there showing that women who were not transfused, the morbidity were low. And then what is bloodless medicine, as it were? This has been discussed since on Monday. But essentially, it is a situation that we use a comprehensive and multiple approach to manage patients to the extent of avoiding allogenic blood transfusion, and also improve patient outcome. Global definition is that patient-centered, systematic, evidence-based approach to improve outcome by managing and preserving patient own blood and promoting safety and empowerment. Essentially, what this means is that if a patient is managed without blood transfusion, it's likely that the outcomes will be better and the patient's condition will also improve more than those that have been transfused. So these are the pillars of bloodless surgery. This has also been elaborated in previous presentation by the presenters of yesterday. The first one is optimizing the hematocrit. And essentially, this will help to the patient to tolerate blood loss. And this is done by using ion therapy and other form of medical therapy to improve the hematocrit of this patient within a short period, so that even if the woman is bleeding, the blood loss can be tolerated. There are so many other ways that this can be done. Then the second pillar is minimizing blood loss. Using clinical assessment for bleeding, pharmacological agent, intraoperative procedures, this can actually be accomplished with most of our patients getting the best treatment that they want. So it's usually good to combine all these methods of pillars of bloodless surgery for us to get the optimal outcome. Then optimizing tissue oxygenation is replacement of the volume that has been lost, oxygen therapy, and reducing consumption of oxygen. This has been done in various ways, which I will not want to elaborate here because it had been discussed at previous presentation. But suffice to say that this will help the result of management to be such that the outcome becomes better than those that blood have been transfused. Why do we need to bother ourselves about blood conservation? First, which is what we know all over, is to avoid risk of blood transfusion, infections, immune modulation, and others. But more importantly, in our setting, cost become a very important factor to institute conservative management. Cost is not only the cost of procuring blood, but to make it safe, storage, and other socio-cultural factors. Because in most developing countries, culture and other social conditions will influence the procurement of this blood. Sometimes it may be linked to certain cultural condition that is available in that environment. And then availability of blood. This is usually very critical because these days donors are not found. Storage facilities are scarce. Screening protocols are limited, particularly in most resource-constrained environment. And because of this, it's better to avoid the use of blood. As has been discussed since Monday, it is good clinical practice for you to consider conservative blood management because it has been shown to give a better outcome than when blood is administered. And in my center, patients that have been sent for bloodless management get the best treatment from all the medical practitioners because many people put up the best to avoid the complication that can occur without the patient getting blood. So because of that, most of the patients have better and more satisfactory management from the society. So it's not only that the blood is not available, there are so many other conditions that will make us to consider the use of blood, the avoidance of blood in these patients. Now let's look at the blood concept of obstetric hemorrhage. The major and the most fundamental problem with obstetric hemorrhage is lack of unified definition. Many settings define obstetric hemorrhage differently, and because of that, it's difficult most time to compare research and to compare notes. And sometimes patient management may suffer, because while some will think of 1,000 meals as a cutoff point, others talk of 500 meals as a cutoff, or 1,500 meals as a cutoff point. Royal College of Obstetricians and Gynecologists define obstetric hemorrhage as blood loss of 500 to 1,000 meals, and severe obstetric hemorrhage as blood loss greater than 1,000 meals, or blood loss of 500 to 100 meals with clinical sign of hypovolemic shock. Because sometimes you may not need to have the quantity of blood to be so much before you define it as severe hemorrhage. For example, women with who were anemic before coming to the hospital, and those who were sick with other form of comorbid condition, which small amount of blood that is lost could tip the patient into cardiovascular instability. World Health Organization defined it as loss greater than 500 meals, severe hemorrhage greater than 1,000 meals. But let's see what others are thinking about. The problem with the obstetric hemorrhage assessment is that clinicians generally underestimate blood loss, sometimes by half, and especially if the blood loss is much. The more the blood loss, the more the estimation is the more the underestimation of blood. And the other important factor to consider is that average blood loss during vaginal delivery is about 500 mils, and cesarean section about 1,000 mils, which almost approximate the definitions of both. Because there are some that define obstetric hemorrhage as vaginal delivery of 500 mils and cesarean section of 1,000 mils. And when you consider this, it means most of these patients may not even be classified as having obstetric hemorrhage. And the physiological adaptation of pregnant women allow blood loss to be tolerated to the extent that a woman can lose up to 1,500 mils before any significant change can be noticed in blood pressure and heart rate. And that means it should be vigilance, not necessarily waiting for the changes that occur in the cardiovascular system of these women before intervention is done. That is why a protocol and a systematic way of making a diagnosis and managing this patient is critical to making early diagnosis, like we will see later in the discussion. One of the challenges we have is not getting the patient for treatment early enough. Laboratory evaluation is generally too slow to be meaningful, and it does not reflect the dynamic condition that occurs in a woman that is bleeding during obstetric hemorrhage. So relying on laboratory investigations to manage this patient may be misleading, because by the time the laboratory result comes, the condition at that time may actually be different from what the laboratory result will give. And this brings a very serious challenge. And that is why most management settings even though the laboratory result is rely on for certain other conditions, but it may not help you in the acute and immediate management of this patient. So it's also considered that these women will be better managed using the clinical parameters, as it were. Having discussed this, the woman that will have increased risk of obstetric severe outcome, bad outcome from obstetric hemorrhage is a woman that has greater than 100 mils of blood loss within 24 hours following birth and continue despite use of initial measures, including the first-line uterotonic drugs and massage. So sometimes the bleeding may not be that you have in postpartum hemorrhage that is pouring and in large quantity at a time. It could be trickles over time. And these are the ones that usually being overlooked. For example, a woman who had a episiotomy that is bleeding, not torrential, maybe just changing parts, over 24 hours, may lose more than 1,000 mils. So a continuous bleeding in that form is also considered as a very important cause of morbidity following obstetric hemorrhage. Now, the table here shows some of the changes that you may need to observe before, when a woman is bleeding. And this table actually explains what I had been discussing, that sometimes pregnant women tolerate hemorrhage in such a way that before the clinical condition changes, it's likely that a certain amount of blood must have been lost. For example, if a woman lost 1,000 mils of blood, the systolic blood pressure is still greater than 100. The heart rate is less than 100. She may just have lightheadedness or palpitation. She may need to lose up to 1,500 mils for the systolic blood pressure to change between 90 to 100 millimeters of mercury, and heart rate of 100 to 120. They just have weakness and sometimes dizziness. She may need to lose up to 200 mils before you have significant change in the cardiovascular system. For example, 3,000 mils need to be lost before the woman is panting for air. These guys try to assess using systematic review of relationship between blood loss and clinical signs to see how this can be used in clinical practice. Their conclusion is that even though there are variations in the clinical findings and the blood loss, the clinical signs and the blood loss, the sign of shock is the most reliable of all to assess the amount of blood these women lost. So by the time that you wait for the shock to occur, that means the woman would have lost up to 2,000 mils to 2,500 mils. So this study has actually highlighted the point that it is not feasible for us to wait for the woman to get to shock level before we know that the blood loss had been significant. Let's see type of peripartum hemorrhage. Obstetric hemorrhage is also regarded as peripartum hemorrhage, usually classified based on the timing of delivery. Antepartum, placenta previa, uterine rupture, placenta abruption, and others. Postpartum, uterine atony, placental factors, genital trauma. The commonest of all obstetric hemorrhage is postpartum hemorrhage. Not only that, the prevalence and incidence is high, the mortality is also high in postpartum hemorrhage because it occurs suddenly and in large quantity, sometimes overwhelm the system, both the personnel and the facility that are available. So it is important most times when protocols are being developed, most protocols will center on the management of postpartum hemorrhage because it's the commonest cause of obstetric hemorrhage. Coagulation disorders, both acquired and congenital, are also available as cause of obstetric hemorrhage. Management of obstetric hemorrhage is centered on the cause, resuscitating the patient, looking for the cause, and then tailor the management to individual pathology. This is very important. Let's see factors that we can use to predict a woman that will have obstetric hemorrhage. Even though prediction does not correlate with the incidence of obstetric hemorrhage. Most obstetric hemorrhage will occur without any risk factors. But the risk factors will help us to plan and have a strategic arrangement for treating this kind of patient. Because if those with risk factors are overlooked, they are more likely to have severe hemorrhage and the outcome that is more disastrous than those who just developed. So, person who had previous postpartum hemorrhage or obstetric hemorrhage like antepartum hemorrhage, postpartum hemorrhage, is likely to be exposed to having another hemorrhage. Anticoagulant during that pregnancy, exposure to it. Gestational anemia. I had mentioned anemia in my introduction. Anemia is such that irrespective of the amount of bleed that the lady has, may tip her into cardiovascular instability, severe preeclampsia, uterine leiomyoma, uterine fibroid. Like the case that we had managed in this center, who had uterine atony, it was because of uterine fibroid in pregnancy. We are going to discuss this in detail as we are progressing. Multiple gestation because of overdistension. Then intrapartum causes prolonged duration of labor greater than this, operative delivery, and placental factors. Placental factors range from retained placenta, morbidly adherent placenta, and other forms of placental abnormalities. This will predispose a patient to having obstetric hemorrhage. So a patient that will have this, it is usually good to screen. There are so many other factors which I have not brought in here. If you look at, I say, factors associated with severe obstetric hemorrhage, there are certain factors that will cause overdistension of the uterus that will predispose to uterine atony that I have not brought in here. But this has been studied to show that women with these factors are more likely to get severe obstetric hemorrhage. And these are the ones that plans must be met in a setting. If it is in a setting that facilities are not there to tackle, should be transferred to centers that can handle that. Now, this is a classification of obstetric hemorrhage. Class 1, 2, 3, and 4. It is the blood loss that is the paramount parameter here, factor to use in assessing the severity of obstetric hemorrhage. But you can see other parameters there, like the blood pressure, hypotension, capillary refill, respiratory rate, urinary output, then others like dizziness and shock. These are factors that, as you are taking your history, clinical evaluation of this patient, you have to note this so that you'll be able to classify the woman, whether she's in class 1, class 2, class 3, or class 4, because management is tailored to each class. For example, if a woman is in class 1, it's likely that the aggressiveness and all the armamentarium of treatment may not be deployed to treat this patient, and those facilities may be free for other people to be attended to, compared to a woman who is in class 4. Class 4 may, in some places that blood may be transfused, is what they use a large volume of blood, up to 20 pints of blood to transfuse to get her out. Whereas a woman that is class 2, moderate management of certain factors can tip the woman into good outcome. So it is always important that while managing obstetric hemorrhage, this classification, as you can see here, this classification is clinical. It is not something that needs high volume gadgets, electronic and all that. It's just for a clinical assessment, which means it can be used in remote places. It can be used in high places, in quote, as it were. We also need coordinated responses and well-developed contingent plan and protocols for managing massive hemorrhage as imperative to reducing mortality associated with obstetric hemorrhage. Each unit that is vested with the management of obstetric hemorrhage must have a planned protocol, a planned way of attending to patients from the diagnosis to what is done step by step, like we have in our center. We are going to discuss this as we progress in this discussion, that it is imperative that a well-coordinated plan and protocols that are communicated to personnel that are involved in this management from time to time, and drills, so that if crises occur, it's not the time that people are trying to find out what to do at any point. It is something that is coordinated, well planned, in a coordinated manner. Then the basic management include monitoring the signs and symptoms of hemorrhage, managing the bleeding, maintaining tissue oxygenation and perfusion, monitor for coagulopathy and its complication. The first point of management is preventive. Preventive management is imperative because waiting for obstetric hemorrhage to occur before treatment is instituted, most likely that facility will be overwhelmed. That is why WHO brought out the form of management that is instituted, particularly to prevent postpartum hemorrhage, which is active management of third stage of labor. This has been evaluated all over, both regional, sub-regional, local, and found out that it has worked to prevent obstetric hemorrhage, particularly postpartum hemorrhage. And it involves using oxytocin administered intramuscularly at the delivery of the anterior shoulder or of the baby. It is given to all women, all pasturant, irrespective of parity, irrespective of gestation. It is imperative that this active management of third stage of labor is instituted to prevent obstetric hemorrhage. The use of intravenous oxytocin, 20 to 40 international units per mil, that is about 150 mils per hour, is acceptable as alternative to the use of oxytocin intramuscularly. Then an IV bolus of oxytocin can also be given 5 to 10 international units slow over 2 minutes, particularly during cesarean section. And it can also be given during vaginal delivery, but mostly during cesarean section. The classification here is 2B, which means it has been evaluated to show that it is something that is desirable for us to. And then delay clamping of cord, the umbilical cord, is also part and parcel of AMTSL. Clamping of cord is a controversial matter, but delay or not delay clamping of cord is very important. It is necessary that cord is clamped at a particular time to allow the blood to flow to the baby and also prevent certain complication in the baby. There's no evidence that in an uncomplicated delivery without bleeding, the accelerated delivery of placenta, this is very important, placenta can prevent risk of postpartum hemorrhage. So delaying delivery of placenta within the 30 and 45 minutes can be allowed because uterine contraction and others will occur during that period so that delivery can be effected to prevent hemorrhage. The delivery of the placenta can be done using control cord traction. This figure, I got it from my participation in the workshop that had been done recently in an issue in obstetric ultrasound scan. Why I got this is that it has displayed most of the drugs that we use in management of third stage of labor in form of prevention. In fact, essentially all the drugs here are used in this management. Oxytocin, like we mentioned, is the key, both in prevention and treatment of obstetric hemorrhage. The oxytocin is given either IM or IV. But the problem with the oxytocin that we have in this part of the world, in the tropic, is that it is heat labor, which means it needs certain refrigeration and other factors to keep it potent. Recently, people have questioned the integrity of the type of oxytocin we are using in our side because of this issue of not having the appropriate temperature to get it to the point that administration will give the potency that we need. Recently, development of heat-resistant oxytocin had been muted, and in some places, they are available to use in obstetric management. We can also use a combination of oxytocin and misoprostol in the form of treatment, not prevention this time around, form of treatment. Misoprostol, we know, is active in contracting the uterus in a sustained manner. And when combined with oxytocin, the duration of action tends to be higher. But the problem with misoprostol is that there are certain patients that it may not be very desirable, very necessary for us to use because of comorbid condition. For example, a woman that has an asthmatic attack or other respiratory factors, problems. So those ones may not be used. Cytometrin is also there. It's a potent, it contracts the uterus in a sustained manner. It's a combination of syntocinon and ergometry. It is desirable too, particularly if there is intractable uterine bleeding. it is good to avoid in women that have a predisposition to hypertension, because this will accelerate that condition. Carbamazepine is currently being considered as a replacement to oxytocin because it is more heat stable. Even though the onset of action is a little delayed, but the duration of action is higher than oxytocin. In some places, it is used as oxytocin is used, even in the preventive level. But most time in cesarean section, it is desirable to use this because it will cause a sustained contraction of the uterus over time. There are other drugs that are very important in contracting the uterus, one of the uterotonics, that can be used to help us manage this patient to have a desirable result. I also got this from there, that there are certain research that is going on, a multi-center research that involve developing countries and some in Nigeria, because of treatment challenges, delayed or inconsistent use of intervention for postpartum hemorrhage. And this tends to be the solution. Because the major thing is that, like I mentioned during my introduction, that there is differences in diagnosis, differences in definition, differences in mode of management. This uncoordinated way of treating obstetric hemorrhage leads to delay in the treatment of this patient. So this method of having a bundle of treating this patient was developed in terms of study. If we consider, the first one is the uterine massage, the use of oxytocin drugs, the use of tranexamic acid, IV fluid, and others, down to when surgical intervention will be instituted. When the result of this will be available for us to use in practice, I hope it will help us to overcome some of the challenges that militate against having effective treatment of this. Tranexamic acid had been used for treatment of obstetric hemorrhage recently. Until recent, it was used in trauma cases and other bleeding, management of other trauma. But the crash study too demonstrates that tranexamic acid reduces the risk of death from bleeding from trauma patient. And the woman study in Obstetric and Gynaecology has shown that it is safe in the treatment for obstetric hemorrhage, both in vaginal delivery and elective cesarean section. So it is now effectively used in obstetric and gynecology to prevent obstetric hemorrhage. It is an antifibrinolytic agent, which mainly tranexamic acid is one of them. The more efficient approach could be to administer tranexamic acid after onset of postpartum hemorrhage. This is what the study had shown. But recently, tranexamic acid is now used as prophylaxis, particularly in women, particularly in women who have predisposing factors to this. The medical management includes using those ones. The surgical management approach that we need to use in obstetric hemorrhage. This includes manual compression of the uterus, packing of the uterus, use of balloon, compression sutures, repair of lacerations and genital tract, manual removal of placentas, and others. But let me say that there are so many points that we have to use to prevent, to have good results when we are treating obstetric hemorrhage. Preoperative assessment and workup and planning. Intraoperative surgical, anesthetic, technological, and pharmacological agent. Postoperative care of this patient. This is essentially the pillars of bloodless medicine. Surgical approach is the use of careful planning of surgery, patient positioning, meticulous surgical technique, and careful hemostasis, mechanical occlusion of blood vessels and local constriction agent used to prevent the excessive hemorrhage. Well, there are so many compression sutures, particularly in postpartum hemorrhage. This is a Bill-Lynch method of doing compression suture to prevent uterine, to treat uterine atony, to prevent severe obstetric hemorrhage due to postpartum hemorrhage. This is another one, and multiple sutures, uterine artery ligation is also there, and uterine artery ligation is done when other form of conservative and surgery fail. So uterine artery ligation may be done in a stepwise manner. Result had been there. Then peripartum hysterectomy is also one of the major point treatment that can be used in the treatment of obstetric hemorrhage. For example, most women that have high morbidity, mortality associated with postpartum hemorrhage is when there is a delay in giving a definitive treatment like hysterectomy. And that is why I say here it is sooner to do hysterectomy than later. And it needs to be performed rapidly. These are some of the other forms. Then intraoperative salvage. This had been done over the years in other disciplines. It was really being done in obstetric practice because of fear of the transmission of infection, transmission of fetal skin and squams, and amniotic fluid embolism. But with the introduction of the filter now that are available, it is now being used effectively. Cell salvage system can provide about 200 ml unit of blood with hematocrit of within 3 minutes. And with this filter, the fear of embolism and other transmission of fetal squams have been reduced to almost minimum. There are so many methods of doing this, but it is in our environment is very expensive for us to do. In some remote centers during ectopic pregnancy, rupture ectopic pregnancy with massive blood loss, the scoop, filter, and transfuse have been done, and with varying results. But with sophisticated machine like the one I'm showing here, it's likely that there will be a closed circuit management of this, which could be acceptable to most people that would not want to have this due to religious belief. Now, this is the protocol that we have in our center. The protocol of management of PPH that we have in University of Calabar Teaching Hospital that has given us the result, the remarkable result that we have. When this protocol is instituted, we hardly run into a woman that will not, we hardly will come to high morbidity as been enunciated earlier. So most patients using this protocol will go home well, and the result is usually very satisfactory. The protocol includes that it is a multidisciplinary group that is put in this area so that you involve the hematologist, the pediatrician, the obstetrician, and others, including the nurses, so that a coordinated factor will be used to manage this patient. The first one is that screening at antenatal care for predisposing factors and previous history, patient identified, will be given special attention. Jehovah's Witnesses are given special attention because some of them will provide the hospital with power of attorney. And because of this, they are treated as special group of patients because of them not desiring blood transfusion. Early hemogram using the point of care is also important. Once a diagnosis is met, this team is activated, and all the protocol that has been set here will be instituted to achieve good result. Oxygen is optimized. If necessary, IV ion and erythropoietin is given. The fluid management is as set up there. We have colloids as well as crystalloid. Tranexamic acid and vitamin K is given early, either as prophylactic or as treatment. Intravenous ion and erythropoietin is given when necessary to increase the production of hemoglobin, as it were, the packed cell volume, and others. Now, we also have what we call PPH team. This one is different from the main protocol, because the main protocol, whether there is PPH or the group is invited in other areas, is instituted. But in PPH, this team is directly involved in managing PPH with an alarm. Sometimes it could be the ward assistant that instigates this. You may not need to wait for a nurse or a doctor to start the process of treating this patient. There's an alarm that once that alarm is sounded, then the team is activated and the necessary action is taken. In women that, let's see this. Then protocol for women who has vaginal delivery. We institute AMTSL. We ensure IV fluid is given, intravenous access is given. Sometimes we give on two hands using size 16 gauge of intravenous cannula. Pulse oximetry is done to check the oxygen tension. We maintain pneumothemia. Pneumothemia, we know that if it is not well managed, it's likely to cause more consumption of oxygen. Then the other management includes the one we put up there. Now, the UCTH experience. There is a bloodless management of severe obstetric hemorrhage with very severe anemia, a case report by Dr. Osara recently. And this is a landmark case because this woman was a 32-year-old para-zero with twin pregnancy and uterine fibroid. who expelled the baby at 23 weeks. After expulsion, she had PPH, which resulted in exploratory laparotomy at HB of 3.3 grams per DL. A total abdominal hysterectomy was undertaken because there was uncontrollable hemorrhage, and the HB reduced to 1.8 grams DL. She received about 4,500 ml of fluid within 24 hours. And this tipped the woman into fluid imbalance and fluid and electrolyte imbalance with HB of 1.3 grams per DL. She had seizures, hypochloremia, as stated there, but it was effectively managed with oxygen and other therapy. That on the 6th day, the electrolyte was corrected and the packed cell volume, the HB returned to 2.7 grams per DL. On 8th day, she was discharged from the ICU and she was subsequently managed. This is the case of a woman that was a 24-year-old para-zero lady in advanced neglected obstructed labor. She came from what we see there, obstructed labor. She attempted to deliver in TBA. We managed with emergency cesarean section using the protocol I have highlighted. The mother and child were alive and with no complication. Another one is this woman who had also a book lady that delivered in peripheral medical facility with acute uterine invasion and placenta accreta. She had a PCV of 20%. She refused blood. She was successfully managed in the hospital using the well-established BMSG protocol. This woman actually was so bad that to even remove the placenta from what you see, it took us a day or two before we can do that because she was very unstable. She was able to tolerate anesthesia for us to reduce the uterus. The challenges we have is attitude of our people that still resist the use of bloodless medicine to manage cases, but the attitude has changed so much in recent times that we believe that most people are now embracing the use of bloodless medicine in the treatment. Institution, equipment, and support are what we need to do what more than what we are planning to do. Now, other factors is that it now becomes a global practice. We said that training curricula should be changed, both medical and basic medical and applied, and also at the postgraduate level to reflect this, because if it is not reflected, it is difficult for people to follow at this level, even at postgraduate level. Research, there's a research that is ongoing, the study of outcome of blood transfusion alternative in women undergoing major elective gynecological and obstetric surgery operation in the University of Calabar Teaching Hospital. It's a comparative study. Those who refuse blood transfusion and those that blood transfusion is accepted. So we compared the two. The preliminary result is very encouraging. Then collaboration with other institutions may be what we need. In summary, what I have tried to say is that most children who experience significant bleeding have no recognizable risk factor. So all patients that comes to us should be screened for possible OH so that acute and accurate management should be instituted. It will be instituted. Given the instability to reliably predict patient at risk for obstetric hemorrhage, all parents should be considered to be susceptible. Extreme vigilance must be exercised in the assessment of blood loss, hemodynamic instability during peripartum period. Thank you very much.